I mean, I happen to agree. I have such a wonderful team supporting all of you and supporting ourselves as a team. I mean, I think that we all just work really well together, and the better we work together, the better we are for you. And so to go on into the next session, I wanted to introduce one of our newest neurologists on our team, Dr. Lugo. He is so wonderful, and he's one of those doctors that reaches out and spends such specific time with our patients and with our families, and spends time on educating and advocating. And so I have asked him here today to really just spend time with you guys on what is it with seizures and safety? What is it? Some common questions that we're typically asked as doctors, even in the Central Valley and all over. What's kind of the medical suggestions that we can give with our common seizure safety? And then what are some of the weird questions that we get asked that, sometimes can have a different answer depending on the doctor that you're talking to. So Dr. Lugo, thank you for being here. Thank you for taking the time out of your day to do this. And so I'll kind of hand it over to you. Thank you.
Yes. Hi, good morning. Thank you for having me. I had not seen that video, so it is a great experience that Soraya had, and I'm so glad that she's seizure free and that we were able to help her. I came into the practice here after that. I've been here only for about a year and a little bit more, but I pretty much trained in a place in Boston where my teachers, they were very in touch with their patients, and it was always kind of like, you have epilepsy, but it's not just leave it like that. We were always trying to get them over support and kind of talking to them and answering questions. And the way I train is that you are pretty much, you become their primary doctor almost, because it is such a difficult and poorly understood condition outside of neurology. I'm glad that Caitlin is doing this epilepsy support group that it's been formed here, because where I trained, we had one as well. And it was super helpful to be able to have parents and patients and even the other doctors just reach out to the team that's doing the support and kind of have that conversation and have that space for parents and to talk among each other, and also to talk to the teams, and also for the older kids that they can talk to other kids with epilepsy. They can understand that they're not alone, that this is not something that's hindering them significantly in most cases. And I'm glad that this is something that we are able to do. So for today, I did want to just kind of go through a little bit of safety and first aids and things that we kind of in general talk about when we diagnose epilepsy. And sometimes we talk about it throughout the time we follow our patients. And the way I wanted to do this is just kind of giving you my little speech that I give all my patients whenever I sit down and we discuss about epilepsy and kind of safety. And it is, the first thing I always say is epilepsy in general is not a life sentence. So you can have epilepsy and your kid and yourself, they can have a normal life. There are a few things to be aware of. And in most cases, and I like to say that because everyone's different and we like to tailor our restrictions and recommendations to every patient. But in most cases, you will be able to have a normal life. And most of the restrictions, if you want to call it like that, are usually already been done by the parents. So it's a lot of common sense things and a lot of things that parents are already doing for their kids. So I always like to start like, children with epilepsy, they can do sports, they can participate in different activities with the family, they can travel, they can study, they can become professionals, and they can do pretty much most of the things that they could do if they wanted to be a successful adult, even if they didn't have epilepsy. The first thing that I always mention is there's gotta be carefulness and preparedness for when they're swimming. So swimming is a big one. They should not be swimming alone. And in general, I say, no kid and no adult should be ever be swimming alone. That is kind of one of the rules of diving. So if you ever took scuba diving classes or something like that, that is the first rule. You never go alone. And the reason is because you don't know what can happen, and you want to be able to have someone that can rescue you from drowning or something like that. In kids with epilepsy in specific, as far as we have control of the seizures, which is defined as 6 months seizure free, kids can go into the pool, can swim and can do everything, but they just have to have an adult that is supervising them, either a lifeguard or an adult that's in the pool with them. And that's something to be able to see if something's happening, get them out, because the main cause of death for people with epilepsy is not their actual epilepsy, it's just drowning. It's a person that gets a seizure while they're in the water, and they cannot get them out, and that is the reason why they pass away. So that's why this is a very important thing. Now, kids sometimes are not seizure free for 6 months, or they haven't gotten to that point. So that is when the recommendation for me becomes a little bit more strict, in the sense of, yes, they can swim, they can go into the water, but they have to have a one-to-one, meaning someone is going to be with them that knows they have epilepsy and understands that he could have a seizure at any moment, and has to be with them all the time. Once we get to that control part, which is that 6 months seizure free period, I think that becomes a little bit more lax, and is more of just them let them have fun, but they have to be supervised. And that is not usually what I say to parents. That is not an overburden, because most parents that I have here are very good, and they're like on top of things when the kids are swimming or something like that. After that, the other thing I like to mention always is heights. So kids with epilepsy in general could have a seizure at any moment, and they could lose consciousness, they could lose their spatial awareness. And if they're in a high place, they should not be looking over the edges, or try to avoid high places, like going up the stairs on their own, on a place where it's not like safe because there's borders, or if it's like a ladder, they should not be going up there alone, or going into the rooftops. All those things, they need supervision for it. And I always say that those are very common sense, because we do that with most kids. We don't want them to fall down from the ceiling, from the roof. But one thing that is not always kind of common sense is bunk beds. So I always say, if you're gonna have a kid that has epilepsy sleep in a bunk bed, they should sleep on the bottom one, for the same reasons. I mean, you can have a seizure and you can fall down. And more than anything is we're trying to avoid more damage, more injury, specific to the head. Because if you have a seizure and you hit your head, it may just become worse, and we just may run into different problems and that we don't want to face at that time necessarily. The same thing goes with anything with wheels. And I like to say it that way, because you can have skating, you can have biking, you can have rollerblading, anything that has wheels, and your kid is going to participate, they can do it. But a helmet is important to have, just because of the same thing. If he falls down, he or she falls down, we want to make sure that the kid is protected and the head is protected, and we don't get major problems from that. And then those are kind of like the big ones that I say for most kids. And then there is kids that are older and they're in their age where they can drive already. And I know here in California, you need a car to be able to move around, or at least to be able to transport yourself. We need, and this is a state law, you need to be seizure free for about 6 months before you're able to get your driver's permit, get your driver's license. But if you already have it, you need to be seizure free for about 6 months before you're able to drive. It is different. It is a different time frame in different states. And you just have to go and look for the local ordinance. And also, I trained in Boston where it was 6 months as well, but I just needed to tell you and document it. Here in California, we are obligated to report it. So as we meet people, we do new diagnosis of epilepsy when they're about 14 years of age. We have this letter that it's standardized, and we send it over to the DMV so that license gets held until we're able to clear them for it. So that is a very important thing. And the idea is you may have a seizure while you're driving, so we don't want you to pass away or have a serious injury because of that. But also we're trying to protect other people in the community, because it's, it's a car you're driving, you could crash into someone or you could crash into something and you cause major damage. So it's a protection to the patient as well as the other people around us, because we have to live in a community and we'll be able to live normally and safely there. And other than that, the other things that I kind of say and I always asked is about cooking safety, fire safety, and I always like to talk about we prefer showers to baths. So showers to baths, it's in a shower, it's highly unlikely that you're going to drown because it's just water dripping on you. So we prefer showers to baths for kids with epilepsy. If they're going to have a bath, that should be supervised. So it's not that you cannot, but it should be a supervision. We always say, I like to always say, don't lock the bathroom door. So I know teenagers and everything, they're looking for their privacy and everything. They can hang a sign saying that I'm in the bathroom, I'm showering or anything like that. But the idea behind that is it's if something happens or you're as a parent are concerned and you want to just go check on them, the door is open and you can go in and just make sure, because if they're having a seizure, they're not aware, they're not able to call you, then you're not going to be able to go in. And I do have a few horror stories from when I trained, and I don't want them to be repeated just because of that. So that's why I always say that. As far as fire and cooking and all these other important things for life as they grow up, they will be able to cook by themselves. They need to be able to do that. I mean, they need to be able to be independent at some point in their lives. And the important thing is just to be careful with them. Just teach them very good about fire safety and protecting themselves. If at all possible, having an electric stove, that's better than having a gas stove just because of the fire. But that's not always possible, but it's good just to have good education for it. I know we live here and there's a lot of outdoorsy stuff going on. Sometimes that happens at night, and we like to maybe do a bonfire or have some sort of fire going to keep us warm and just entertain, and that is okay as well. But it's just making sure that they don't jump into the fire or they're not around the fire and may fall down. And like I said, this is not an overburden to the parents. These are things that most of the parents are already doing just because they are aware of their kids and just want to make them safe. And that is kind of my general discussion about seizure precautions and seizure safety in terms of what they can and they cannot do. After that, I always talk about what to do with a seizure. And this is very tailored. So this is very different for every patient, just because every patient has different types of seizures. But in general, if you have what we call a generalized tonic-clonic seizure, which is this seizure that happens that you see in TV where you shake all over, you don't respond, and it's difficult to see just because they can be very scary. There's a few things that I always recommend. The first thing is, if this is one of the seizures that's happening, is to place the patient on its side. It could be right side, left side, doesn't matter. The idea is that with these type of seizures, sometimes we can vomit. And if that vomit happens, we need it to go out and not into their lungs because it could be worse. So that's why we put them on their side. We try to make sure that they're in a flat surface so that they don't get harmed. And anything around them, try to kind of clear the space so that they don't get harmed with other objects. Important to do is never put anything in their mouths, because they might clench or they might just be shaking their mouths. And if you put your finger on it, or if you put something on that, you could either harm your finger or you can either break their teeth because it's just too much and it's harmful and it's strong. There was a myth a long time ago that people would swallow their tongues if they're having a seizure. That is completely impossible. So it's not something that can happen. So we don't need to put anything on their mouths to prevent that from happening. The other thing I always say is time it. Every neurologist will have different instructions about when to use a rescue medication for their patients, in particular based on their seizures. But timing it is going to be very important because you're going to want to know when to use that rescue medication based on the instruction that your neurologist gave you. And then one that is kind of like, I like to say it because it helps us, but I always understand that seizures can be scary and they can be very stress inducing. But if you can at any moment take a video of it, that would be very helpful for us and your neurologist, just to see what happened, see what that was. And we trust you telling us what happened, but it's stress inducing, and having a video sometimes helps a lot to look at the details and kind of what happened at that time. So that's kind of my general gist of seizure precautions, seizure safety aid that I tell every parent, and then I'm open for questions and see what do you think is anything different, or you think there's something else that should be said, or if you have any other questions based on your particular kids with epilepsy or any other people that you've heard.
Feel free to unmute yourselves if you guys have any questions, or Dr. Lugo can answer for you. If not, I'll ask one that I've been asked several times before. So I'll start the questioning out. So obviously when our teenagers, Dr. Lugo, get a little bit older and we're trying to work on our independence and we're trying to be more responsible, a lot of times I personally have heard parents ask, well, when is it appropriate for my child to be responsible for their own medications? And I know that a lot of doctors have a different perspective on this, and it can become an issue, but what would be your suggestion for a family that is working on helping their child be more independent? And what does that look like?
Mm-hmm. Yeah, that is a good question. And I see one in the chat, and I'll address that one as well. So there is, and in medicine in general, in pediatrics, there's this big movement that's called transitioning. And it's kind of a strange term because we use it for a lot of different things in jargon and in the normal speech. But when we talk about it in pediatrics in general, is the transition of a kid to adulthood in the sense of their responsibilities towards what they need to do about their health. And most of the places I've seen that they're doing a clinic like this or just kind of working towards this is in epilepsy or diabetes, because it's chronic conditions that they need to be managed. So in general, around age 13, 14 is when we start this process. And what that entails is, around this age is when I start talking to the patient and talking to them and saying, do you know what's your medicine? What's the name of your medicine? How many pills do you take, or what's the milligrams that you're taking? And I start making them more responsible of knowing these things and being aware of them. As we grow older, when they're about 15, 16 years of age, they already can, with the supervision of their parents, they can call the pharmacy and kind of get a refill. And is that something to work with the doctors, but also work with the family? You know, this is the time when you need to teach them so that they can make that phone call. Because if we do that in a gradual way, eventually when they turn 18 or when they turn become more independent, maybe go away to college or something like that, they already done it a few times with the parents supervising them, and they feel less scared of doing it, and they're able to get their own medication. But yeah, it's a process that starts around 13 years of age. I like to start it, and it's ongoing. But the idea is that while it is happening, and I do this, and a lot of doctors do this as well, is, you know, you're already 13, you're already 14. What's your medication? What are you doing to stop your seizures? And then this is a process that kind of keeps going, and they will answer me the questions. And then at some point, it becomes a conversation between the neurologist and the patient, because eventually they're going to be going on their own to their own appointments. I have a few patients that turned 18 while I've been here. And the parents actually sent them over on their own, and I was happy because they knew what their medicines were, they knew what to do, and they had good questions. So it's always a way to make them more independent. Any questions regarding that before I go to the next ones here on the chat?
Well, I would say too, like, part of the conversation that we follow up with that, I mean, being a social worker, part of the conversation I would follow up with the advice that you give to families would be, while you're counseling them and while they are becoming more dependent, it's something like, hey, put a reminder on their cell phone so that they know when they need to take the medications, how many times they need to take it, and to follow through with that as a parent, because we do know that our teenagers aren't always consistent like they should be in a nice way. And so just making sure that while we are providing them the independence, that we also are still monitoring so that we know, hey, we don't want them to go with missing a dose. And things happen, people forget, there's a grace, but as a parent, making sure that they're still going to be safe and showing us that responsibility. So it's kind of like they start telling you the truth, you give them a little more leeway. It's kind of the same thing with the medication as far as that goes. So thank you.
Yeah. So I see here in the chat, Amparo, I think, how do we go about after the seizure has passed? That's a good question. So the first thing is every kid is different. So we have a generalized seizure or any type of seizure, and they have what we call the post-ictal state, which is right after the seizure stops. A lot of kids are confused, are out of it, or sometimes they're just sleepy and can't speak. So the important thing is those first few times, even the neurologist is learning about your kid's epilepsy. So we're trying to figure that out as well. But in general, if it's a shaking seizure, the shaking will stop and the patient will be tired. Sometimes they will be very sleepy. Sometimes they will be very tired. Rarely, but it happens, they may get aggressive or irritated, but that's very rare. And the thing to do about that is just kind of check on them. So if they're asleep or they're not talking, but if you're able to like wake them up and they're kind of brush you off or just act like a normal person being trying to wake them up, that is normal, and that is good. That's the important thing that we want. They can sleep it off and that's fine, but just kind of go about it is just trying to check them. In general, what we call the postictal state, so that period of time after the seizure, it can last anywhere from 1 hour to 2 hours. Sometimes it's shorter, sometimes it's longer. Everyone's different. But for those patients that are starting their journey into managing their epilepsy and kind of managing breakthrough seizures and all of this, a good time to check on them after the seizure is like every 15-20 minutes at first. Just kind of make sure that they wake up and they're fine, and then every hour, just making sure that they're fine. Once you see that they're back to their normal self, then you don't need to keep checking on them. I mean, it's just back to their normal self. But until they're back and they're sleepy and all that, let's say every 15-20 minutes you can check them. Just make sure that they wake up and they kind of, even if it's mumbling, they just kind of brush you off. If you see that that's not happening within the first 30 minutes, then that would be a reason to call the neurologist, or that would be a reason to go to the emergency room and get them checked out. It might be that that's their post-ictal state and that's how they do, and they just don't respond until like an hour later, but we just need to make sure that we understand that before saying don't do anything. Does that make sense?
So let me clarify. So when you're telling a parent to look at how long the seizure, what the recovery phase is, right? So after the seizure is stopped, how long is it taking them to come back to their normal state of mind? Is that what you're looking for? Are you looking for them to come back and be able to have a conversation if they were prior to seizure, and kind of get up and do what they were doing prior? Can you clarify a little bit for me as a parent? When you guys are saying recovery phase, when is it that, hey, we're kind of safe to send them back to school, let's say, or we're kind of safe to go about doing what we're doing the rest of the day? So what does that look like?
Yes, so it would be back, what we call back to baseline. You're just, you had the seizure, you are sleepy, you're confused, you're whatever your post-ictal state or your recovery phase looks like. And that may take X amount of time, and we need to figure that out slowly as the process goes. But that phase stops when your kid goes back to acting like his normal self. Like even if his normal self, even if he's acting just kind of calm, but he's awake, he's responding, he's making sure that you're talking to you and responding very well, that should be fine. Or if this is a very active kid and they're like, you know, acting normally, that's okay. So it's different for everyone, but I would say that is the moment where that recovery phase stopped, and he should be fine doing any activity right after that.
And that's what you ask families to report to you, is how long does it take to return to that baseline?
Yes.
Got it. Okay, thank you.
So it says, how do you counsel teenagers about recreation drugs, for example, marijuana? Well, in general, our recommendation is don't do it. So there is no, so marijuana is legal right now in California, but you have to be over 18 to do it. So that makes my job a little bit easier because I'm a pediatric neurologist. I can just say don't do it. But in general, when we get 18 years of age, or people just have more questions, all drugs, or at least most drugs that are for dependence, and I'm including alcohol and tobacco into this, will increase seizure frequency or may trigger seizures. Even marijuana, so there is a component of marijuana that we're used for some medications, the CBD component, but we know that the THC component, which is the other part of marijuana, does have some seizure-inducing effects, and we're still learning about it, we're still studying it, but in general, my recommendation below 18 years of age is don't do anything. Above that, and you know, alcohol is 21, so I kind of followed what the law says, but in general, drugs and epilepsy don't mix well. Usually what you're gonna get is you're gonna get a trigger. A lot of kids that I have, I always tell them, you know, when you're 21, you're gonna get to your legal drinking age, and it does not mean that you will never ever have to be able to take a beer or have a drink. You can do that, but it has to be on moderation, because just kind of getting drunk or having high amounts of alcohol will trigger seizures even when you're on the medication. So that's one of the biggest triggers for epilepsy in the adult world. And in kids, we also, in teenagers, we kind of always say, you know, this is something that needs to be managed and needs to be controlled to avoid having seizures. And I tend to, with teenagers, because usually the question comes from the parents first, and then the teenagers are the ones that when I talk to them on their own, that's when they come in and ask the questions. I tend to say, you know, first of all, if you have a seizure, I cannot let you drive. So that's one thing that it kind of helps to avoid it. And then the other thing is I say, you know, seizures are dangerous. These seizures are not something to laugh about. You're on your medication. This is something that's helping, but there are things that can make them worse, and kind of getting drunk or using drugs or you doing all these things will make you have a seizure, or highly likely to have another seizure. So it kind of making them very self-aware of themselves and their condition is also very helpful to kind of the counseling part of the of recreational drugs. Any questions on that?
I think that's great. I think that, you know, we do ask that of our teenagers, and those can be mostly, you know, 12 and up. Our private conversations with a physician, and we want them to be honest with us, because that is going to, you know, direct sort of the conversation that we have with them, and really educating them and saying, okay, you know, you're old enough now to make these decisions, but we want to make sure you're making healthy decisions and what that's going to look like for you. And so, you know, just be aware that we will be asking them these questions, along with many others that are really important in them becoming older and becoming independent and knowing more about their medical condition and what they're going to do with that the rest of their life. So we do give them that positive reinforcement, in a sense, like Dr. Lugo said, that, hey, you're going to want to drive one day. Hey, you're going to want to be active in all these different things you want to do. And if you have a seizure because of maybe you're taking recreational drugs, or because you're not taking your medication on time, that is going to limit your possibility of being, you know, more free and more active and independent. So thank you. I appreciate that.
Yeah. So Amparo, there is a question you have here. Is there any common science you know about breakthrough seizures? I'm not exactly sure what you're asking. but I can talk about breakthrough seizures a little bit. So in general, when we talk about epilepsy, there's when we talk about epilepsy, there's not a big guideline saying, this is the medicine that's going to cure all epilepsy. We have to figure out what type of epilepsy the patient has. We have to figure out how it behaves. And then we have like 25 to 30 different medications that we can always pick from. When we do that, we always pick the ones that have the less side effects and the most efficacy to control the seizures. And that's what we try to do as what we call first line medications. Sometimes people with epilepsy, they can have what we call difficult to treat seizures or refractory seizures, meaning that we did pick a good medication and that medication just not doing its job very well. It's not stopping the seizures. And that's something that can happen. And that's what we call breakthrough seizures. A breakthrough seizure is we are on treatment, we are taking medication, and we still have a seizure on top of that. In general, the most common reason why someone has a breakthrough seizure is because they didn't take their meds for whatever reason. It could be they forgot, it could be they just don't want to take them, it could be insurance issues and it didn't get to them on time, but just not taking them is the most common reason why breakthrough seizures happen. The second most common reason is that we are underdosed. So we try always to go to the lowest, most effective dose to try to avoid side effects the more that we can. But we always have a maximum dose, and we always go up on that based on, in children, based on weight, but also based on breakthrough seizures or events that are happening, and we want to try to stop those. We always try to get to the maximum dose of a medication before starting a second one if needed. But sometimes that's something that happens and we might need more than one medicine to control the seizures. Now, as far as common science or common knowledge is what I said, most of the time when a breakthrough seizure happens is because you missed the medication, which is the first question that we ask whenever we get called. This patient had a breakthrough seizure. The first thing I ask is, did they miss any doses of their medicine? After that, there are other triggers for epilepsy and for breakthrough seizures, including drugs and alcohol, which we would just talk about, but also fevers and illness will lower your seizure threshold, meaning that if you're having a fever or you're having any sort of illness, your chances of having a seizure are higher, even on medicine. And sometimes we do get breakthrough seizures on a control patient on a medication with a fever or with a medicine. And usually at that time, what I do is just increase the dose just to protect them. And then on a follow-up appointment, we have a discussion about, should we go down on the dose again to whatever you were before, or should we just keep it on this dose because he's doing well? But that's what I can say about breakthrough seizures, just in general, without having a particular patient in mind. Does that answer your question? Oh, that's a good question. How many breakthrough seizures before medication is adjusted? Again, it is depending on every patient, but in general, our goal is to make patients seizure free. So ideally, if I get a call saying, I had a breakthrough seizure, I will increase the medication. If I get a call, if I get a follow-up and talking to the family, they tell me, he'd been on the medicine, he hasn't missed any doses, he had one seizure about 2 or 3 days ago, I will increase the medicine. If the seizure happens like 2 or 3 days after the increase, I just tend to think, the levels are still not there in the blood, and we just can give him a little bit of more time. So it depends on the situation. Hormones. Yes, there's a lot of research into trying to understand hormones and epilepsy. In general, we tend to think, well, it's hard. So there are some epilepsy syndromes that get better after puberty. So there's a few epilepsy syndromes that are what we call benign, in the sense of that they go away, and that stops after puberty a lot of the times. As a rule of thumb, we tend to think that epilepsy that started after puberty tends to be lifelong in general. It might not be, but it tends to be. And epilepsy that starts before puberty tends to be more benign and stops because because we are able to stop it after puberty. But in the changes of the hormones don't always correlate with worsening of seizures or not, but it can, and it's different for every patient. So when I see a patient going through puberty and their seizures getting worse, I tend to sit down and investigate a little further and deeper into this patient's condition. I don't know if I answered that question or if there's any other follow-ups to that.
Well, I guess if we're sticking on the puberty and hormone topic, I, you know, being a social worker, we've had a lot of experience, most recently with a lot of our teenagers, our older teenagers, young adults, coming in with pregnancies. And so I know that a big question that a lot of our families or even teenagers will ask is, well, can I have a family? Is this medication going to be dangerous to the child? Or most of the time they're coming in after the fact. We don't even know they're pregnant until they come. And so what would you suggest as a doctor with family planning? I mean, it's something that I think we need to talk to our teenagers more about. But what is family planning with seizures, and what does that look like?
Good question. So it's been very well studied. So there's a few medications that, Angelica, that's a little difficult to say, but no, it's been very well studied. So we actually kind of, one of the things that we take into consideration when we start a medicine, especially in females, is the risk of having issues with pregnancy or having issues with a baby being born after pregnancy, exposed to different types of medications. And that is something that we take into consideration. There are a few medications that we have tested in pregnancy that tend to be safer than others, but there's always a risk of having some sort of side effect or some sort of problem with the kid growing up with all of the medicines. Now, that said, we've studied it enough that we know that having active epilepsy, meaning you're having seizures while you're pregnant, it's worse than even the worst of the medicines that we have for pregnancy. So that is, whenever we get a patient and they tell us, I just got pregnant, we tend to not change medicines. We say, we need to stay with this medication just because it's been keeping you seizure free, and having seizures is worse than not having them. In general, we try to tell our patients, let us know before you're gonna get pregnant. In pediatric neurology, we don't really deal with that a lot, but let us know before you're gonna get pregnant if you have plans, so that we can sit down and have a discussion about it, okay? And kind of everyone understands where we're at. One thing that most pediatricians will do and should be done by everyone is, especially, sorry, not done by everyone, done by females, is just be on folic acid. So that is kind of one of the biggest recommendations. So if you're gonna get pregnant or you're thinking about getting pregnant, folic acid is something that we will recommend. But in general, just being on folic acid will help prevent a lot of the different problems that can happen during a pregnancy to the baby when it's born. But yes, the easy answer to that is just you will stay on the medicine and we'll try to keep you seizure free. There are some medications that we need to get levels and adjusted throughout pregnancy because the hormone changes change the medicine itself. But in general, we just keep you on the medicine till that you're seizure free throughout pregnancy.
So don't stop your medication. If you know someone who happens to find out they're pregnant, please call us as soon as possible. Don't stop your medication. That's something that we see quite often. They will call us and say, well, I've stopped my medication a few weeks ago. So we just want to make sure that, family planning is an option. And we are more than happy to, when you're old enough and mature enough, have those conversations. But we want to make sure that everyone's going to be safe. Absolutely.
Yes. And in general, don't stop your medicine unless you speak to us. We are happy to have a conversation and kind of explain the need for the medicine, or sometimes there's maybe no need and we can just sit down and explain and kind of see how we can take the medicines away. But the reason is a lot of our medicines cannot be just taken away. We just need to taper them down because it might be dangerous to stop them just quickly. And there are some patients that just need the medicine, and if we take them off, they will have seizures. So it is important that if that is something that you have questions about or considering, just want to have a second opinion or something like that, just please let us know before you stop medications. Because like I said before, the main reason why you get a breakthrough seizure is not taking your medicine. And we don't want that to happen without having a good discussion and you understanding all the risk and factors of that decision coming forwards.
Any other questions? No? All right. Thank you so much, Dr. Lugo, for spending your time having this conversation with us. I think it was very helpful, and we went over a lot of really, really helpful tips and tools, and some conversations that people are really kind of hesitant to talk to their providers about, to talk to the doctors about. So I think that by just getting this out there and saying, like, look, we want to make sure that you're taking your medication as prescribed, and if you have side effects, please let us know. Don't stop your medication. Those types of conversations, I think that we assume are common sense, but it's not necessarily what happens. And so just to be honest with us and let us know, hey, this is what I'm experiencing. And our doctors are always willing to talk about, different options for every family, and each patient's different. So thank you so much for going over their general safety tips and techniques with us. And I appreciate it. We will be also doing the same conversation later on this afternoon in Spanish. So if you guys know anybody who would benefit from having this conversation, who doesn't speak English, then please send them our way, and we will be happy to facilitate that conversation with them. So thank you so much, Dr. Lugo.
Well, thank you for having me, and thank you for all the questions. I hope I answered most of them, or at least all of them, if possible.
I think it was wonderful. Yeah. Thank you so much.
And thank you for going over that, because I was one of those not too smart that I did stop taking my meds when I got pregnant younger. So thank you.
Well, no, that's good to know. That's good to know, Jessica. Thank you for saying that, because you've had
that's very important to go over.
Yeah, you've had 2 kiddos with seizures, right? And I mean, your suggestion with obviously the choices that you made, what would you tell kids, right? I mean,
definitely talk to your doctors. Even unexpected pregnancies, but still talk to your doctors. As soon as you know, tell them. Tell them what's going on so they know what to do.
Yeah, and you have 2 beautiful boys. So
yes, 2 beautiful boys.
And we got to walk through that process with you. So thank you for sharing. I appreciate it.
Yes.
Oh yeah.